And now, live.
Ashok, please, she is not able to join. Vidhisha.
Okay, I'll call us. Anyways, good evening and welcome to OrthoTV MOA Voice Webinar Series. For further proceedings, I'll hand it over to Convener Dr. Manoj. Over to you, Manoj.
Yeah, very good evening to all of you. And I again welcome you all for this another academic session of MOA Young Surgeon Forum. And today we'll be having this special episode with first time in the history, a woman's wing from Maharashtra will be having presentations with the WOICE WOICE MOA collaborative series, which will be starting. And today we'll be having our first webinar. So for further proceedings for today's webinar, I would like to ask our MOA President, Dr. Wasudeo Gadegone, to give a brief outline about the idea for this session.
Welcome all delegates of OrthoTV Maharashtra Orthopaedic Association and faculty of this very prestigious webinar of Women's Wing of Maharashtra Orthopaedic Association. I have started since January when I took over as a president Young Surgeon Forum, where young surgeons all over Maharashtra, they are presenting their work. Then I thought, why not the women wing of our Maharashtra Orthopaedic Association should be formed, and they should be given a chance to deliver their knowledge as well as their work, and they will get a very good presentation, discussion and everything. So I started Women's Wing of Maharashtra Orthopaedic Association, and it will be a very good platform for all young orthopedic surgeons, women orthopedic surgeons to deliver and to present their work. It is mostly a case-based discussion so that we can have a good discussion. Now I hand over mic to Rujuta Mehta for introduction of all guests, those who are going to present their scientific work for this forum. Thank you very much.
Good evening, everyone, and thank you very much, Dr. Gadegone sir. खरं म्हणजे आजची क्षण ऐतिहासिक आहे. महाराष्ट्रामध्ये एज्युकेशनल आणि शैक्षणिक रिफॉर्म ही एक पद्धती आणि एक आपली विविधतामध्ये एकता ती एक ट्रेडिशनच आहे. अहिल्याबाई होळकर पासून महाराष्ट्र हॅज बीन नोन व्हेरी मच फॉर इट्स strong women presence in every which way. So with this, what to say, a very divine sort of blessings with us, Jizabai, and the land of such great women, it was very nice when we saw that when we had WOICE, or Women Orthopedic Surgeons of India Collective Empowerment, which is the short form is WOICE. When we saw how many are actually from the different states, we realized that the majority ones are actually from Maharashtra, and most of them are actually already forward in their thinking. They're already established, they're dynamic, they're outgoing. And hence, a matter of great pride to me today that we are sitting here with the first state in India which is launching its own women's wing. And therefore, we have called it Anmol, which is Active Network of Maharashtra Orthopedic Ladies. So from WOICE, we now are Anmol. And what better than to see some of my own students, my colleagues. And as you know, all ladies are always young. So we will have senior and junior presenters in this series again and again. My dear friend Vinoti Sheth, who is a professor and head of a unit at SIAN, Vidhisha Kulkarni, a leading trauma surgeon and upper limb surgeon who will be joining us. Young and dynamic Chasanal Rathod, my pet protege and always one of the most leading people in BOS, and Anisha Valvi, again, she has forayed into arthroplasty. Neha, the super dynamic arthroscopy surgeon. Ishani Chaudhary and Tanvi Shinde. Ishani is a budding PD pod and deformity correction surgeon, and even Tanvi Shinde has done a lot of the detailed introductions will be given by the panelists. So without much ado, I will take this opportunity to congratulate Neha on very well thought out case discussions. and Manoj for coordinating all this. Thank Dr. Gadegone sir once again. And of course, our strong and reliable Ashok always for giving us a platform to showcase our work. So Neha, over to you.
Thank you. Thank you very much for the kind words, Gadegone sir and Rujuta ma'am. Now I'll just introduce our panelists. As Madam has rightly said, Dr. Chasanal Rathod is practicing pediatric orthopedic surgeon in Mumbai, attached to Narayana Healthcare SRCC Children's Hospital and various other hospitals across Mumbai. Her special interests are in pediatrics and subspecialty, are neuromuscular condition and gait analysis. Our other panelist is Dr. Anisha Valvi. She is DNB and ortho and assistant professor at LTMMC Sion. She is a joint and trauma surgeon. So with this, I would like to hand over it to panelists to introduce and invite our speakers, Dr. Chasanal and Dr. Anisha.
So thank you, everyone. And without any delay in the program, I take this pleasure to introduce respected Binoti Seth ma'am. Ma'am is professor and unit head at Sion Hospital, and she is teacher to many students, has authored various books and articles. So today it's a very it's a privilege for us to have ma'am to present as one of her best cases in the first webinar for the women's wing. Thank you, ma'am, and please over to you, ma'am.
Yeah, can you see my screen?
Yes, ma'am, it's visible.
Yeah. So the case I'm going to present is a 15-year-old male who came to me with restricted range of motion of his left shoulder, and he had progressive shortening of arm. And on further inquiry, the parents denied any other positive history in his childhood, and he had a normal perinatal history. On examination, his findings were really interesting. He had his restriction of his forward flexion and abduction. And abduction was almost restricted up to 60 degrees, beyond which the scapula would start moving. And his humerus was shortened by almost 8 centimeters. If you can look from behind the second photo, it's almost just half of the contralateral right side. So we were really surprised what this condition. Sir, Dr. Manoj, look.
Ma'am, there's some break in your audio.
And I think the connection at her end is a bit poor. Yeah. So we lost connection with madam. Yeah, she's back.
You can rejoin, madam. You can rejoin.
Binoti madam is still, we can restart screen sharing.
Yes, ma'am, you are visible. The screen is visible.
Yes, ma'am.
Unmute yourself, ma'am.
Yes, am I heard now?
Yeah.
Yes.
Yeah. So Dr. Manoj, do you want to take a call on this? Like what can you make out of this X-ray and from a history and examination where there is restricted movement and shortening of the arm?
I think with 15-year-old having such a severe shortening without any history of any trauma, I think we could find out some few meta or epiphyseal dysplasias with or there are something called as even sometimes disappearing bone syndrome. Even in adults, we can sometimes find the whole of the humeral head is absent.
So he did not have any other joint involvement or any other positive history. The only problems were confined to left shoulder. Yeah. And the head was very much visible, but if you can make out from the X-ray, there was significant varus in the humerus. You know, the head was almost, if you see the physis, almost vertical. The greater tuberosity rising very, very high from the humeral head and neck. And the distance between the humeral head and the lateral cortex was markedly shortened. So all these findings were suggesting towards a humerus varus. We confirmed this with a CT scan where we could see that there was a significant varus deformity of the proximal humerus. And we realized that what we were dealing with is a condition called as developmental humerus varus, which is an upper extremity analog of a much commoner condition, which is a developmental coxa vara. We see quite frequently coxa vara, but this condition is very, very unusual. And this happens because of some growth arrest of the medial humeral physis. So because the medial side of the physis stops growing, the head slowly goes into significant varus. And if you see this nice diagram where the affected humerus and the unaffected humerus are overlapped, and you can see how progressively the humerus starts going into varus and also starts becoming shorter. So this was quite an unusual and a rare presentation for us. And the etiology is many times trauma or some infection in childhood, which are sometimes neglected. But as you rightly said, we should always look for some skeletal dysplasia like focal fibrocartilaginous dysplasia or spondyloepiphyseal dysplasia, and some hematological conditions also present like this. But otherwise, if you are ruling out everything, then it can also happen as an idiopathic variety, which probably was our case. So now what to do for such a case? I was also seeing such a case for the first time because it is pretty rare. So Dr. Gadegone, would you now want to take a call on how would you treat this patient?
Madam, there is a still epiphysis is intact here.
No, so this is not the representative I've just given. This is this patient who is presenting to us.
But actually, to tell you very frankly, madam, for the first time in the 40 years of my practice, I have seen this case. Therefore, it is not a right occasion to comment on this thing. And this is the first time.
For me also, when this came, it was first time. So even I looked up the literature, which unfortunately was very scanty because there are only few case reports and very few series because these are very, very rare cases. But what they had described was something called as a corrective osteotomy, lateral close wedge oblique osteotomy of the proximal humerus. So this was what I could make out from the two papers which I went through. And then we also decided to give a go. We discussed with the parents about the possibilities and the result of this. And we did this surgery in a modified V chair position. A deltopectoral approach was used. We tried and put a K-wire in the distal fragment. Initially, we had planned our osteotomy like this diagrammatic representation, what was described in the paper. And after putting the distal K-wire, then I marked the osteotomy, what I had planned on paper. You can see these drill bits which are there marking the osteotomy. And then we made a cut of the osteotomy, confirmed it on C-arm about the osteotomy closure. And then once the osteotomy was closed, we fixed it with 2 K-wires and also another K-wire from proximal to distal. And we got a fairly good result and fairly good correction of the varus deformity. Post-operatively, we immobilized the child because he was an adolescent and he was a compliant child. We immobilized him in just a chest arm strapping. But if this is in a younger child, then sometimes you should put them in a shoulder spica. K-wire was removed after the radiological union was achieved. So this was at the end of 6 weeks, where once we removed the K-wires, this was the range which was there. And from this onwards, we started worked on his range of motion and strengthening exercises. This was just when we had removed him out of the chest arm strapping. So already he was getting 90 degrees, and beyond that, he continued having further improvement in his shoulder range of motion. He was so happy that now he wanted lengthening of the arm. So we also now decided to go ahead, looking at our good result of this abduction osteotomy. We went ahead with lengthening using the limb reconstruction system. And we started lengthening at the rate of 1 millimeter per day. And progressively, we found very good regen rate. So this was at 2 weeks. This was at the end of 1 month. And this was at 2 months when it was already showing good amount of regen rate. 3 months, this was the picture. And by 6 months, he had a fairly good amount of regen rate, which was well consolidated. And total, we got about 8 centimeters of lengthening. And from this radiological humerus varus picture, we could get this final radiological result. clinical result, from what it was looking just half of the opposite side, now almost it was equal on both sides. And what was most satisfying was his range. He had almost full abduction. You could see those ugly scars of surgery because of the pin tracks and some pin tract infections during the course of lengthening. But functionally, radiologically, and clinically, he was very, very happy, and so were we. So as I said, there are very few articles and very few literature on this, just short series of 6 children by Peter Waters, where he had also got good result and improvement in neck shaft angle and good range of motion. And some people from China have started using just a linear osteotomy and fixing with plates so that the mobilization can be faster. So what we learned from this case, what I learned, and probably which was satisfying, that though being a very, very rare disease and being not trauma or infection, but an idiopathic variety in our case, we could get good results in his abduction and forward flexion by this valgus producing lateral closing wedge osteotomy. So pre-operative proper planning and meticulous technique was probably what helped us in getting a successful outcome. And then later that lengthening was always the icing on cake, because we got very good result later on. So I think this was a good case for me.
Yeah.
Thank you so much.
Yeah, I think it's an amazing, wonderfully done and very unusual presentation. It's a very wonderful start for this webinar. Any opinions or any discussions? So much of shortening with varus is, it has to be some developmental.
No, sir. What is there is that the proximal humerus physis is the main contributor of your humerus length. Almost 80% length of the humerus occurs from there. So then, because this thing is developmental, it starts very early and the contribution starts reducing right from there. So they have significant shortening. But because it is upper limb, most of the time it doesn't affect your function. But, at that adolescent age, when they start having problems in their, sports activities, or they feel embarrassed while, clothing, combing, a lot of activities require this abduction. So that is when that time they present. So because it is a main contributor, the shortening is expected because of that growth arrest.
Okay.
Madam, is there any possibility of a very childhood early infection which is resolved automatically with antibiotic and rest and something, and he presented after 10 to 15 years? So many times it happens in other joints also. Is there any possibility like this, that they thought infective pathology to start with in the beginning, which was neglected, and probably it resolved itself, and then he had developed shortening? But it's a wonderful case. I have never seen in my life. Of now I am in orthopedic now 1980. It's near about 41 years, but it's amazing. One thing I want to mention here now Dr. Sergio Rowensky from Brazil, he had started abduction osteotomy in post-traumatic varus of a humerus. That improves the function also. So it is under the publication, his article, and he had shared with me some of the picture. So you have done a wonderful job, madam. Congratulations.
Just to answer your question, many times, as you said, the neonatal, if the child is in septicemia, one particular joint gets neglected. So it could have been there, but in this case, there was no history. But that is the most common cause, a neonatal sepsis or trauma.
Ma'am, I would like to ask whether the humeral head was normal in morphology, because in cases of infective joints, the humeral head would have been deformed probably.
Yeah, so if it is a septic arthritis, then the joint and the humeral head would be deformed. But if it was a metaphyseal lesion, or sepsis involving not the humeral head per se, but the metaphyseal region, it is still possible to have a good.
But I am not the pediatric orthopedic surgeon, but there is a controversy still whether the infection start first in the joint or in the metaphysis. From metaphysis go to joint, or from joint to metaphysis. Still there was a controversy. I am not aware of this thing. You can throw some light whether the infection start first in the metaphysis. Majority of the time it has been taught to us like this. But there is another version that if you get a intra-articular pathology, that can also affect because there is a capsular attachments are at different level, and probably there is a flow of infection from intra-articular to extra-articular. Do you know something about it? You can throw some light on it.
Most of the time it's a metaphyseal infection, but again, it depends specific site specific. Suppose, as you rightly said, if it's a femoral head, which is completely intra-articular, then both are almost connected and then, one leads to the other. But say in tibia, you have a hairpin bend and the most common focus is the metaphysis. And then if it progresses, it can go to the epiphysis. So maybe region specific, but sometimes both are associated with each other.
I have one last question. Is like any problems you faced while lengthening, because this was an adolescent who had a shortened limb and then you have lengthened it almost to normal as compared to the other side. Any nerve stretching or any problems which you could have anticipated?
Not per se nerve stretching, because we were going at the normal rate of 1 millimeter per day, but you have to be careful about the joint contracture. So we were ensuring that he does his elbow range of motion and pendulum exercises for the shoulder. And while passing the pin, you have to be careful that you're not injuring the radial or the other nerve. Surprisingly, in children, in humerus, they do lengthen and they throw the regenerate very well. I think there's no problem of, delayed union or, delay in the regeneration. So it's a very good. Yes, sir.
Do you use a percutaneous method or an open method for pinning, distal pinning? Because proximal pinning is not a very much problem, but distal pinning, there is some problem of neurovascular. So do you use a open method or a closed method for a pinning?
Not a complete close, but you make a small incision, use a drill guide. You use a guide and through that, and avoid pure lateral. You can go little enterolateral, posterolateral, avoid direct lateral. And always use a drill guide and do a mini open, go till the bone and then, dissect till the bone and then you can pass.
So what you can additionally do is sometimes if your anesthetist has a good nerve locator on table, then they can help you locate the nerve and show you where it is passing. You mark out the path and then decide your pin placement. We've had one radial palsy with these kind of cases, but as Binoti has shown the literature, even us with a pure pediatric orthopedic practice, I don't think even I have seen more than 5 or 6. So I think that's a reasonable number, and it is a fairly rare condition, but what she's done is absolutely right. The only thing I wanted to add to Neha's question is that the deformation is definitely there if there's a definite history of sepsis, and there the problem is when the GT is abnormally larger than the head. The head glenoid part is usually congruous. It's because the GT is not able to clear for during abduction. And that's where it starts impinging, and then they get symptomatic and then they come to you. So,
okay.
Those cases, better to, if you are fortunate and if you are well versed with fixators, you can try to do the abduction osteotomy as well as, so in the proximal thing, you use your pins in such a way that they fix the osteotomy, and then do again a distal corticotomy and go down. But the working space is very less. Remember that. So there's a huge learning curve, and you've got to be a real expert with fixators to attempt both together. Otherwise, what she's shown is the ideal way to go about it.
Ishani, your father is online. He can throw some light on it.
Ma'am, would you do it with one fixator in a go, like ma'am said? If suppose we don't want to do it in stage procedure, then with a rotating attachment in the monolateral.
Definitely. But as I said, in this patient earlier, the indication was just, improving the range of motion. We were not focused about the lengthening. Even the patient was not demanding because it was upping. But then when he got such good result, he was greedy, and even we thought we'll give it a go. But otherwise, if the indications were clear right from beginning, as Rujuta and you rightly said, you can minimize the time of, the treatment by combining two, but you require experts, because you are doing angulation, distraction, and you do bifocal problems. So,
I think
and sometimes putting pins in very proximal humeral head may be a little difficult, and, hold and all may be difficult.
Okay, so fantastic case. Neha, can we move ahead?
Yes. Our next speaker is Dr. Vidhisha Kulkarni. She is an orthopedic surgeon and associate professor from PGI Meerut. She is hand and upper limb surgeon, and she has many presentations in national and international conferences. Dr. Vidhisha, ma'am. Yes, she's there.
Hello, Hello.
There was some problem with the technical,
गुरुजी
and
नमस्कार.
it was difficult for me to unmute.
गुरुजीला नमस्कार सांगा माझा.
हो सांगते. Shall I share the screen?
Yes.
Yes, ma'am, please.
काय केलंस? काय आहे काय वेगळंच?
Madam is upper limb trauma surgeon.
Can you see my slide?
No, ma'am. We are not able to see.
Share the screen, madam. Share screen.
I am trying to share. तू बंद केलंस काय?
Ma'am, you open your PPT on the desktop and then press share screen.
It was open to close केलं. PPT. Where is the PPT? हे PPT. हे minimize correct minute.
हा फोरमचा हा फायदा आहे मॅडम. You understand the difficulties of connecting so many issues, how to share, how to stop sharing. So,
अरे हे नव्हे रे, हे presentation. ते बंद कर.
I think the pandemic has really taught us a lot of things, and it is the best thing it has taught us is to have patience and understand another person's kind of predicament. So Vidhisha, if you can hear us.
Yeah, I am hearing, but see, I am using another laptop. I am not used to it.
So what I am suggesting is let the person, whoever is used to that laptop, run the slides.
Okay.
You sit to the side of him and speak.
Yeah. आता हे Zoom कुठे गेलं? Zoom कुठे गेला? Zoom minimize केलं का? Zoom कुठे गेला? अरे अच्छा. थांब, share. Share होत नाहीये.
Ma'am, meanwhile, can we have next?
हा तोपर्यंत तयार करा.
I think we can have another presentation. I think Dr. Tanvi.
Yes.
Anisha, would you do the need?
Yeah. Let me introduce Tanvi. So Tanvi is a MSD NB FCPS ortho, and she has done her MS from GSMC Mumbai, and she is an FCPS gold medalist. She has done her fellowship in shoulder surgery at Princeton, then also in knee surgery at London, and she's a currently practicing plastic surgeon at plasty and arthroscopy surgeon at Shinde Hospital in Sangli. So Tanvi, would you like to start sharing your screen and go ahead with your case?
Sure, ma'am. Thank you. So can you see my screen now?
Yes, we are able to see you.
So I'm going to present a case of total hip replacement done in a case of ankylosing spondylitis. So this was a 41-year-old male, a known case of ankylosing spondylitis. He came with severe pain in both the hips along with restricted movements. He also had difficulty in day-to-day activities, and he was not taking any regular medications like DMRDs. So as you can see in this X-ray, both the sacroiliac joints are completely fused. Both the hip joints have reduced joint space, and there was a lot of fibrous tissue and restricted mobility. This was his pre-operative gait. As you can see, he could barely walk, and he was also not able to sit properly because of the contractures. So we planned a total hip replacement surgery for him. THR in ankylosing spondylitis can be a complex issue because of multiple issues associated with it. And it needs a preoperative planning, not on the surgeon's perspective, but also with the anesthetist perspective. It also has got a surgical technique which is different from other THRs, and a post-operative protocol considering complications should be considered beforehand. So pre-operative evaluation, if we consider any inputs on what will be the anesthetist perspective regarding inducing these patients.
It's mainly difficult intubation.
Yes, but ma'am, mainly we go for spinal and epidural anesthesia in these cases. So yes, but if spinal and epidural anesthesia is difficult, intubation, baby fiber optic guided should be anticipated beforehand. And then we need to have a ENT specialist or fiber optic intubation ready in that case if we are not able to give spinal or epidural anesthesia.
Dr. Tanvi, can you please tell what were the deformities pre-existing in this patient?
Ma'am, I'll be talking about this later. So
Okay.
actually he was having flexion deformities, and the pelvis was neutral. So he was not having any coronal plane deformity, but flexion deformity was definitely there.
Right.
So beforehand, knowing the cardiopulmonary function helps a lot to analyze the risk of pneumonia post-operatively. X-ray of lumbar spine or cervical spine should be done. We have to evaluate for spinal epidural or even a general anesthesia, as Neha ma'am said. And the rigid cervical spine can be an limitation for intubation. So ICU backup is also essential in in many cases because of the multiple comorbidities. So from a surgeon's perspective, involvement of the spine to rule out any spinal deformity or pelvic obliquity should be evaluated, and status of the other joints, and also the integrity of sciatic nerve. Many times these patients are on DMRDs. So we have to talk with a rheumatologist regarding stopping these medications beforehand, and so that we can go ahead with the surgery, and then then after the surgery we can again reintroduce those medications. Again, age and activity of the patient should be considered, and their expectations from surgery. So as Anisha ma'am asked, these were his x-rays. The spine was completely fused. As you can see, it is classical bamboo spine. So whenever the patient has hip and spine involvement in an ankylosing patient, how would you go ahead? Whether you go with the spine surgery beforehand or whether you go with the hip surgery? Anisha ma'am?
Yeah, so in case if the patient is having spine deformity as well, for example, if there is a kyphosis pre-existing, if it is a kyphosis where it is up to 20 degree of kyphosis on X-ray, and you are planning to do THR, so up to there you can give the patient according to the native acetabulum. But however, if there is further kyphosis for every 10 degree further kyphosis, you need to increase the you need to place the cup in a more what do you say, you have to decrease the less inclined
version,
and
yes,
the version you have to decrease.
yes,
However,
yes.
if you are going to make the anti-version more, because in kyphosis beyond 30 degrees, the patient will try and walk with hyperextension.
Yes,
in such
absolutely.
a case, the cup will become more open, as in the acetabulum will be more open anteriorly. And there are high chances of the hip to dislocate anteriorly.
Yes.
So you need to see that the cup position for these patients should be less inclined. And for every further 10 degree beyond 20 degree of kyphosis, for every further 10 degree of kyphosis, you need to place the cup less inclined and more anteverted.
Yes, absolutely. So many times these patients also have kyphotic deformities. So in these cases, surgery of the spine is recommended before hip because the severe kyphotic deformity can lead to anterior dislocation, as Anisha ma'am just explained, because of the compensatory pelvic hyperextension. And also hyperextension of immobile spine can lead to vertebral body extension fractures while even positioning the patient. So it is recommended, and it has been published in JBJS, that spine surgery, if it is severe kyphosis deformity, should be considered before doing a hip. So implant of choice has been a matter of debate over the period of years for these patients, because previously cemented total hip replacement was the modality of choice, but in recent years, cementless THRs has also been done and have been proven to go in a long way. So implant of choice, I think, should be dependent on the age of the patient, and again discussing the options with the patient. Manoj sir, do you have any particular opinion regarding the implant choice in these patients?
Yeah, I think the main concern will be these are usually younger patients.
Yes.
And usually I like to go with ceramic on e-poly with these kind of patient. Try to avoid ceramic and ceramic especially.
Yes, yes.
Yeah.
Yes, I agree with you, sir. So many of the recent studies have shown that even uncemented hips can go for about 10 to 15 years minimum in these patients. Previously, it was thought that aseptic loosening will be more if we use uncemented hips because of the joint forces are being higher in these cases. So surgically, if we consider, we'll see the position of the patient to be kept in these particular patients approach. Identifying of the joint line can be a difficult if it is completely fused joint, and sometimes even fibrous ankylosing joints can also cause problems even in dislocation. So if you do a cut of the neck in situ, just go on rimming over the neck cut, and if you see a foveal tissue, you know that that's a joint line. Even use of a C-arm intraoperatively helps a lot. As these patients have multiple soft tissue deformities like flexion deformity or fixed adduction and abduction deformity, they need a lot of soft tissue releases like adductor tenotomy, iliopsoas release, or anterior capsulotomy. And a pelvic obliquity is an issue, and if there is a sagittal plane obliquity, it is recommended that if there is 10 degree of malrotation above 20 degrees, cup is modified so that it is 5 degrees less inclined and anteverted. So I'll just show a pictorial presentation of this. So my choice of position is in lateral position and a posterior approach. So knowing your inclination and anteversion is very important in these cases. So usually we use a 40 degree of inclination, but if the patient has abduction deformity, the usual 40 degree of inclination will be less and the cup will be more vertical. So that if the patient has abduction deformity, you have to adjust your inclination, and if the adduction is there, again make sure that your inclination is not much. So in lateral X-ray, as we discussed, as Anisha ma'am also explained, if they have a kyphotic deformity, there is a chance that they have a pelvic hyperextension. So in pelvic hyperextension, if we keep the normal anteversion, the cup is likely to be more anteverted and they may have anterior dislocation. So for every 20 degree of, every 10 degree of malrotation above the 20 degree kyphosis, cup should be 5 degrees less inclined in these cases. So doing pelvis lateral X-ray pre-operatively helps knowing the degree of pelvis hyperextension. So we did a staged hip replacement using ceramic on poly uncemented for this patient. And post-operatively, we gave prophylaxis for heterotopic ossification. We can give indomethacin or low-dose radiation, but my choice is indomethacin because radiation can have implications on wound healing. So this is his 2-year post-operative X-ray. As you can see, there is around grade 3 Bruker heterotopic ossification around the left hip, but it has not stopped him from doing his daily course. So this is 2 years down the line, and he is able to do his activities of the daily routine. So heterotopic ossification can be a problem in these patients. So Gadegone sir, have you seen the grade 3 or grade 4 heterotopic ossification in such cases, and if they cause any problem in mobility?
Actually, this is one of the danger of doing surgery in ankylosing spondylitis. That formation of the heterotopic ossification, and I probably one must take a consent also, because then after forming a heterotopic ossification, it is very difficult to treat because you have promised for a good joint mobility, but things has worsened again. So it is a possibility, and therefore one must explain, and it is a we cannot just predict that what will happen to this patient. Suppose within 6 months there is no ossification or heterotopic ossification, then patient is okay. Otherwise, you can get any time within 1 year.
So
I think on the
Brooker,
next
grade
day of
1 or
the
grade...
yeah, sorry, Tan.
Yeah,
So
please,
here
please.
On the next day morning of the surgery, as in post-operative day 1, you can give a single dose of radiation, which is a short radiation of 700 to 800 rad next morning, 350 from the front and 350 from the back to prevent heterotopic ossification, and with the beam on the linear accelerator only on the capsular area. So that will prevent such occurrence, such ossification from happening.
Actually, in my residency, when I was in KM, we had given radiation to 2 of our patients, but one had developed wound complications, and having wound complication is THR is like a dreadful scenario. So I'm a bit afraid to give radiation actually.
What wound complication?
The
Prolonged
wound
healing
dehiscence was there. Wound dehiscence was there, yeah.
All right. And how long did it take to heal?
Almost it took 3 weeks to heal.
All right. Okay.
Yeah. So Brooker 1 or a grade 2 heterotopic ossification is seen in most of the cases, and the severe ones is lower incidence. And I have also gone through the literature, but none of them has suggested a re-surgery for even a severe heterotopic ossification. So complications most commonly seen in these patients are intraoperative fractures because of their stiffness, anterior dislocation if we don't consider the associated deformities. A sciatic nerve palsy can occur, especially with those typical ankylosed cases, and a septic loosening can occur. So to conclude, a specific patient factor should be considered while planning a total hip replacement in an ankylosing patient. Pre-operative planning is very, very essential, including pre-anesthetic checkup and surgical perspective. Intraoperative vigilance is necessary to prevent complications, and post-operative heterotopic ossification can be prevented with prophylaxis, and it can provide long-term pain relief, improve mobility in patients with ankylosing spondylitis. Thank you.
Tanvi, very nice, crisp and clear presentation. So while we are asking questions to you, I would like to request Vidhisha ma'am to share screen. Any questions for Tanvi?
So Tanvi, in this you did not have any coronal plane deformity. However, if you have coronal plane deformity with adduction deformity on one side and abduction deformity on the other, which hip you would like to operate first?
Actually, ma'am, I would go with the patient having maximum pain on the whatever side he has. If he has adduction or abduction deformity, we can always change the inclination accordingly. I don't think it should be a problem otherwise.
Because many a times, if there is no spinopelvic deformity or the SI joint is not fused, as in if there is no scoliosis or there is no fused SI joint, then we tend to put the cup in optimum position, whichever it is, where there is a fixed deformity. However, if the deformity, the spinopelvic deformity is going to be corrected post-surgery, if it is not a fixed deformity, spinopelvic deformity, and you have a raised hemipelvis with an adduction deformity on that side, I will try and prevent to, if there is an adduction deformity, I'll try and prevent to put it, avoid a horizontal cup basically, because once the pelvis which is higher, the moment it comes down, it will become further more horizontal.
Yes, yes.
Which we tend to do.
Yes.
So, and in a case of, even if you're going to do it stage a week or 2 weeks or a month, 2 months, a month apart or anything like that. So, and in the case where there is an abduction deformity, you tend to put it vertical.
Vertical,
So,
yeah.
and you might tend to go according to the native, and you might tend to go a bit more vertical because of the deformity. However, if you put it vertical, the cup will become more vertical once the pelvis comes, goes back on the up level, as in it levels up. So that's why you need to like maybe stage, and if you're going to do bilateral, like maybe a week apart, or bilateral at the same setting, a few people try to go for anterior approach, bilateral anterior approach. In such cases, or even lateral approach, it's better to do the abduction deformity first than the adduction deformity, so that
is positioned more
yes,
normally, yeah.
Yeah. And pre-operatively, you can join, if you're giving lateral position, lateral decubitus, and you can join the posterior superior after positioning. More important that you level the table also. Because many a times the anesthetist, they either give head low
or head high. Yes.
And then you might tend to, place the cup accordingly, or there might be an error in the judgment.
Yes.
So that you need to check the position of the table. Also, if possible, join both the posterior superior iliac spine draw, and then you have it in a mind whether there is a deformity of if there is any spinopelvic deformity.
Spinopelvic deformity.
Yeah, so that you will get a better idea about when you are operating. So, yeah.
That's an excellent case, Tanvi. We have got with all the practical points which are very essential while understanding going for a hip replacement in ankylosing. And thanks, Anisha, for all those excellent comments.
Tanvi always presents nice cases. Actually, this is, I think, we have invited for 2-3 times.
2-3 times. Yeah, I think we were having the previously as well. Yeah.
Thank you, sir.
Vidhisha ma'am, you are able to do your screen sharing?
No, I'm trying to do.
Okay, I think we'll go
मॅडम
ahead.
तुम्ही काय करा, पेन ड्राईव्ह मध्ये घ्या ते प्रेझेंटेशन आणि दुसऱ्या कॉम्प्युटरवर जाऊन करा.
Madam, just log out from the Zoom and reconnect again. Maybe start the laptop.
Are you able to see my screen?
No, ma'am.
No. मला तर इथं दिसतंय.
तुम्ही पेन ड्राईव्ह मध्ये घ्या
mail
मॅडम.
the PowerPoint to one of us. We'll do that. We'll start with Ishani. Meantime, ma'am, if you're okay.
Okay.
Vidhisha, ma'am.
We'll start with Vidhisha.
Okay.
That's a good idea. Vidhisha, email it to Chasanal. She'll run it for you.
I'll run it for you. So next we have Dr. Ishani Chaudhary. She has done her MBBS from KEM Hospital and DOT from Sancheti Hospital, Pune. And currently she's working at Center of Elizaro Techniques at Akola, and her fields of interest are pediatric, deformity correction, and limb lengthening. So over to you, Ishani. Please share your screen and start your best case.
Thank you, ma'am. If I could just request you to also allow screen sharing from the other platform, which is Dr. Ishani Chaudhary, my other.
All are allowed to share. So you have to just press share screen. All the viewers and all the participants are.
Thank you. Thank you.
नाही ते शेअर स्क्रीनला क्लिक केलं की वरती ते हे येते हो, चूज व्हॉट यू शेअर म्हणून येते. मग
Yeah. So yes. Good evening, ladies and gentlemen. And first of all, I want to say it feels very good to say ladies and gentlemen while addressing a crowd of orthopedic surgeons. And this is all thanks to the tireless efforts of all the stalwarts at Maharashtra Orthopaedics, and because of which we are having the first of its kind, the Women Voice MOA Anmol Series. And I'm really grateful and thank you so much for allowing me this opportunity to present my best case in this webinar. I'm Dr. Ishani Chaudhary. I'll be presenting my best case, which is congenital pseudarthrosis of the tibia. I'll jump right into it. So presenting the history of a 4-month-old girl, which was brought by concerned parents. She had a deformity in her left lower limb. The left leg was more bowed as compared to the right. The parents said that this was present since birth. So now on examining her, it was visible that there was an anterolateral bowing of the tibia. This was at the middle and the lower third junction. This junction and this deformity was not mobile. It was painless. There was some limb length discrepancy, but that was minimal. That was less than 1 centimeter. Now, along with the deformity, there was also this skin presentation. This photograph is recent, but it was also present when the child presented. And this is something known as a cafe au lait spot, indicating that this girl had neurofibromatosis 1. So along with the anterolateral bowing and the neurofibromatosis, we come to the diagnosis that this was a case of congenital pseudoarthrosis of the tibia. Just giving you a quick brief history about what this is. It's a rare disorder which occurs in 1 in 2.5 lakh children. It's frequently associated with neurofibromatosis 1. And so the typical feature is the anterolateral bowing. And what is pathognomonic is the fibrous hematomatous tissue which is present and the pathological periosteum which is present, which has increased osteoclastic activity and which usually leads to fractures, poor union, and then refractures. So this is classified, as we know, by the Crawford classification. There's the Boyd classification, and then there is Paley-L-Rosassi classification. So now the parents, we had a discussion with the parents, and they were told the nature of the disorder and that routine follow-up and examination and radiological records will need to be maintained. The child came to us at 4 months and then at 8 months of age. And as you can see, as it progresses, the deformity and the limb length discrepancy was increasing. The management protocol was explained to the parents, which was once the child starts walking, it would be functional bracing and surgery as soon as possible as the parents consent. All was going well. This was the child at 19 months of age. And then she was put in a brace when she started walking. Once while she was walking at home without the brace, the child had a fall. And this is what it led to. So there was a fracture in the tibia. The fibula was fortunately intact. A new plan was devised and explained to the parents. So the child was put in a plaster immediately without reducing it. The plaster was kept for about 2 months. Later, she was shifted to a brace. So the fracture basically happened at around 2 years of age, and due to COVID and parents' consent and hesitation, finally the child presented back to us at 3.5 years. So this is the girl, pre-operative photographs, and this is the full length X-ray of the child pre-operatively. Now, as per Dr. Paley's classification, the latest one, that's from type 1 to type 4C, basically because there was anterolateral bowing as well as a fracture in the tibia, this girl was now mimicking type 3. So the treatment for which was given by Dr. Paley himself, which is the cross-union protocol, which was what we have followed. Now, what is the cross-union protocol? This is basically pre-operative bisphosphonates to be given, complete excision of the hematoma, fixation, cancellous bone grafting to be done, and BMP, which is followed from type 1 to type 4B. So since she fell in type 3, this is what we followed. So pre-operatively, the bracing was done till she presented to us for surgery. 2 weeks prior to the surgery, at a local pediatric unit, she was given the zoledronic acid, which was according to her weight, which was 11 kg, so 0.025 milligram per kg, which was given to her. After that, sharing the surgical technique. So on table, the patient was supine after exsanguination, the tourniquet was applied. Now, a large longitudinal incision was taken that covered the pseudoarthrosis site as well as the cross-union site for enough dissection to be done in such a way that the anterior compartment was reflected, the interosseous membrane and was taken care of, and then the fibula was also exposed. Medially longitudinal fasciotomy was done to fasciotomy for the deep posterior compartment was done. All this so that we reach the pseudarthrosis site. As you can see, both the tibia and the fibula and the fibrous hematomatous tissue is seen. Now, this is the most important step, which is excising the hematoma. We start the excision of the hematoma anteriorly, and this is what happens. So as you can see on the image on the left, this was the Amas hematoma which was removed, but that's not all. One of the most important steps of this was to go circumferentially and take care of the hematoma from the remaining portion as well as the fibula. So this complete hematoma excision was done. After that, the bony edges were visible. So after the bony edges were visible, they were squared off in such a manner that the deformity was eliminated. And after that, maximum point of contact was achieved after squaring them off with a nibbler. So then the fixation of, so these ends were opposed, and the length of the tibia as well as the fibula was taken, and then the fixation was started. So the tibia is fixed with the fascia dual rod. So this is basically a rod which contains the male and the female component. So I have the rod with me here. This is the female component and this is the male component. We started off with first inserting the male component. So before inserting the male component, a very important step was to pre-drill the medullary canal, recanalize the medullary canal. So the proximal fragment as well as the distal fragment was recanalized. The male component was inserted in a retrograde manner. So starting from the proximal fragment going all the way up. As you can see, starting here at the pseudarthrosis site, going up all the way and inserting in such a way that it went a little beyond, it pierced through the proximal tibia. And then once the reduction was done at the pseudarthrosis site, it was hammered back to reach the distal end. After the tibia male component, fascia dual nail male component was put in, anterograde, the female component was put in. The tip of the female component was made sure that it did not remain in the joint, and there was free motion which was possible. Next was the turn to fix the fibula. So that was in fact done from the distal fragment first. It was hammered through a little lower. The pseudarthrosis site was at the site. It was hammered. It was reduced and then hammered back proximally. As you can see, there was intraoperatively the elimination of the deformity and decent fixation. Now, this site was later on prepared to receive the graft. So burring was done on the lateral aspect of the tibia and the medial aspect of the fibula. A wet mop was kept, compression dressing was given, and the tourniquet was released. I'm sorry. Before that, we inserted the low profile plate, which was basically a very thin profile 2 mm metatarsal plate, which allowed 3 and 3 screws above and below the pseudarthrosis site was put in so that it did not disturb the fascia dual nail. After that, wet mop was put in, compression dressing was done, and the second stage of the surgery started, which was harvesting the bone graft by decalcizing the ileum. A long incision from the ASIS almost up to the PSIS was taken. After retracting the obliques, the iliacus taken off from the tables, taking care that the lateral femoral cutaneous nerve as well as the iliohypogastric nerve just beyond the midway, with a thin and a very sharp osteotome, slowly and carefully from the anterior to the posterior and from superior to deep, centimeter by centimeter, the tables were separated. As you can see here, these tables were separated. And these are the intraoperative C-arm images. On the right, you can see that the two tables are separate. With the help of a sharp curette, maximum amount of cancellous bone graft only was taken. We got about 20 cc of bone graft, which was cancellous bone graft, which was harvested. Then periosteum, so this is the harvesting of the cancellous bone graft. Then the periosteum, which was stuck to the iliacus, was taken out to be used further at the pseudarthrosis site. After which closure was done. With the fascia, closure was done and a drain was put at the bone grafting site. Now we come back to the third stage of the surgery. We come back to the pseudarthrosis site. All the harvested bone graft which was taken, which was about 20 cc, was put in between the tibia and the fibula. In this case, as per the original Draut-Paley's cross union protocol, there is BMP which was mentioned, but the patient was not affording, so we did not put any BMP in this case. There was periosteum which we had harvested, that was put in between the two ends of the tibia. And after that, after all of this had been packed, the fascia was closed and the closure was done. After which an above knee cast was placed. The patient was followed up regularly at 2 months, 3 months, and regular x-rays were taken. So here at 4 months in the x-ray, in the AP lateral as well as oblique views, you can see that there is union between the tibial bone ends as well as between the tibia and the fibula. At 6.5 months, the patient had just presented last week. So you could see a solid cross union which is present between the tibia and fibula, as well as the two ends of the tibia. So the reason I say solid is because there is a index which is called as a relative cross-sectional area, which turned out to be 0.53, which is shown as per these post-operative X-ray measurements. And here is the child. This is her right now, 6.5 months, approximately 7 months post-surgery. I'm not sure. Yes, the video is playing. So she is weight bearing well. She's currently in a plaster and she's weight bearing well and walking well. So in summary for this case, preoperative zoledronic acid, 3 stages of the surgery with excision of the hematoma, the fixation with the rod and the plate and the fibular wiring, the harvesting of the cancellous bone graft and the packing of the graft, along with post-operative prolonged cast followed by bracing and regular follow-up with x-rays, and then post-operatively 2 doses of bisphosphonates to be given, was the treatment summary for my case. Thank you so much for the opportunity, and please, I would love to answer any questions.
Thank you, Ishani. That was a very nice case. And we, knowing that CPTs have a history of non-union and recurrence, refractures, we hope and wish you luck that there is good union and you are able to do subsequent lengthenings as well. Yes,
stop sharing. Ishani, stop sharing.
Sure, sir. Thank you. I will stop. Yeah. Thank you, ma'am.
Yes, it's a wonderful presentation, Ishani. Wonderful presentation.
Thank you, sir.
पिताजी का नाम रोशन कर रही है तू.
Thank you, sir. So he's given regards. He was in the OT when you had asked questions from the first case. Thank you.
ठीक है. मला एक विचारायचं आहे की the trans-epiphyseal pin introduction.
Yes, sir.
Is there any problem in growth afterwards? Because we have to keep the longer period of time this rod.
Yes, sir.
There is a chances of again refracture. Therefore, internal fixation should be kept for a longer period of time.
Definitely.
And you are putting the rod with the screw through trans-epiphyseal. So is there any problem in the epiphyseal growth? What is your observation?
Sir, as of now, in this case itself, it's a short follow-up. But as per what they say is, once these children actually start weight bearing, it helps in the end. The growth is not really affected as per, the growth is not really affected as per what I have read in the literature, but I will go through it again regarding the fascial affection of the growth.
And I think that can be taken care with subsequent lengthenings which will be needed in future, sir. So currently our primary aim is to get union at the pseudarthrosis site. So I think we can focus on that part. Ma'am, any comments from Binoti ma'am?
Yeah, so
Yeah.
What I wanted. Go ahead, Vinoti.
So that's the threads of the rods, they are within the epiphysis, and actually they are not across the physis. So there are in the actual sets which are there of the international companies, there are various sizes of the threaded portion. So the aim is to not put the thread in the physis, and in that case it will not affect any growth. But if you don't have the proper threads and if they cross, for the stability purpose, then there is a chance. But ideally, if it is done within the epiphysis, then there is no question of growth arrest. Yes,
Ishani, what are the chances of recurrence of hematoma in progressive follow?
Sir, if the complete excision is done, then the chances are low. But if, say, the fibula is missed or circumferentially it's not done, then the chance of a recurrence is definitely there. And if also if bisphosphonates are not given, then the resorption chances are also higher.
But the bisphosphonate introduction in the treatment of pseudoarthrosis, it is now a recent introduction, not it is a very old introduction.
Yes, sir. Yes, sir.
So
yes.
bone morphogenic protein and bisphosphonate is a recent introduction, but I have no experience. Probably Milind must be having some experience.
Sir, in the last year, there have been 4 cases of CPT which have happened, in which we have used BMP in one of the case, and that has shown very promising results. The follow-up is again short. It's been only 8 months for that case, but the cross union was seen pretty early by 3 months. So BMP showed a promising result, and so that was one. But we didn't use it in this patient.
Wonderful presentation, stage-wise. You understood everything, and probably all participants also they have understood. So next,
okay, Neha, we go ahead in the interest of time,
madam.
Because otherwise these are endless discussions. But these are great cases. Yeah, let's go ahead.
So first of all, I thank Rujuta, Neha, and Dr. Gadegone sir for giving me this opportunity to present my best case. When this topic was given, can you share the next slide, please? So when the topic was given, I was a bit confused regarding what case to be presented amongst the all trauma, floating elbows, floating shoulders, polytrauma, neglected trauma, and complex articular trauma. So after contemplating for a while, I realized that the shoulder joint is the one which is enjoying freedom of nearly 360 degree of arc of motion. And it is very, very difficult to get back to the pre-injury level of forward flexion and abduction, especially in 3-part and 4-part fractures and those associated with fracture dislocations. So I thought this fracture is routinely treated by all surgeons, but there are associated difficulties, drawbacks, and the learning curve is quite long. So I am going to present a 3-part fracture proximal humerus successfully done in 3 patients with slight modifications. As we are aware of high complication rate associated with open reduction internal fixation of this proximal humeral fractures, according to the literature, the rate of reoperation is as high as nearly 14%, and loss of reduction 12%, with screw cutout nearly 11%. So we often also see a vascular necrosis. Next slide, please. After anatomical neck fractures or after fixation of 3-part or 4-part fracture dislocations, avian is not uncommon. Next slide. Inadequate reduction also we commonly see because of improper alignment of the head with the shaft, improper fixation of the proximal fragment, inadequacy of fixation, or missing the head fragment totally or GT fragment completely, leading to failure of fixation like this. And what implant we have these days is not a versatile design enough. It cannot compass all the head fragments. And we need additional stabilization of the tuberosities or the head fragments in the anterior or posterior zone. Otherwise, if the screws are not put through the jig, we may end up with either anterior segment fixation of the head or posterior segment fixation of the head. Too proud placement of the plate is also not uncommon, since in comminuted fractures, it is difficult to palpate the tip of the GT, and the fracture geometry may put the plate quite proud, that to restrict abduction beyond 90 degrees. Next slide. So even after proper placement of the Philos plate, slipping of the GT from the plate itself, escaping of the small GT fragment is not uncommon also. So we have to be aware of all these fragments, as we are not treating only X-rays. We should be skeptical with respect to our fixation and the functional outcome. Next slide, please. So this is how, if the screw length is not properly chosen, the screw may penetrate the head, maybe in the follow-ups due to collapse of the head in osteoporotic bone. Next slide. It is very, very important to check intraoperatively our fixation in different planes of rotation, nearly 9 planes, so as to avoid this complication. Next slide. So even the satisfactory looking post-op X-ray, we are not sure that this will proceed to good union or functional outcome. See, this AP X-ray is looking okay. In lateral X-ray, there is convergence of the proximal fragment locking screws. Although it looks stable, what happened in subsequent follows, there is loss of reduction, posteromedial displacement of the head fragment, maybe because of improper fanning out of proximal fragment locking screws. So looking at all these complications, the learning curve is definitely high. Next slide. So now coming to my case, a series of 3 cases, a slight modification done in each case. This young girl presented with fracture dislocation, anterior dislocation of the head. Next slide. The CT showing slight comminution of the GT. So this was done through deltopectoral approach, and the head was removed with the help of shanspin put through the head and sutures through the subscap. And there was a temporary K-wire put, and the radial X-ray was okay. This went to uneventful union. The patient also came for implant removal. And in this case, next slide, almost equal range of motion was achieved in the shoulder, full external rotation, internal rotation, as well as forward flexion and abduction. Next slide. Similar case in a young adult, 3-part fracture with sort of osteoporotic bone. Again, comminution of tuberosity. Next slide. This is the CT and treated similarly. What was done additional, there was tension band wiring done through the tuberosities to achieve secure fixation of the tuberosities with the shaft. And the valgus reduction was maintained with calcar screw and many locking screws in the proximal fragment. And rehab was started as soon as possible. And this is 1-year follow-up of the same patient with good union and functional outcome. Another case, 4-part fracture in a young adult. So there was associated coracoid fracture also. The head was dislocated anteriorly. This was fixed with coracoid screw. There was persistent dislocation in spite of fixation. So intraarticular K-wire was kept for 3 weeks, which was removed at 3 weeks, and the mobilization was started to have this functional outcome. Nearly good internal external rotation with forward flexion and abduction. Although there is radiological absorption of the tuberosities, the function was excellent. So in conclusion, the successful outcome in proximal humeral fracture depends on valgus reduction of the head, maintaining the neck shaft angle greater than 120 degrees, maintaining the retroversion near normal with maintenance of the Gothic arch. It is important to achieve secure tuberosity fixation either with sutures or with tension band wiring. Align the GT distal to the head at least for 5 to 7 mm. And it is important to place the locking plate properly lateral to the bicipital tuberosity and 8 to 10 mm distal to the tip of the GT. Stable fixation of the head fragment and tuberosities fragment to the shaft is important with proper spanning of the head fragment with number of locking screws, at least 5 to 6 in number. And of course, with good rehab, you can get successful outcome in proximal humerus fractures. Thank you for your patient listening. I would like to have any questions.
Madam, wonderful presentation. Actually, one thing I want to comment, because you have got a very good movements. It is because of not only the anatomical restoration, but respect to the soft tissue. You can get a very, very good X-ray and anatomical restoration, but functionally this shoulder, you don't get a overhead abduction. So that is how, but you have got it. It is because of the, while doing a surgery, respecting the soft tissues is the most essential part of the surgery, apart from valgus and putting the calcar screw in the proper position.
Right.
Ma'am, I had one question. Like in all your cases, you got good union, and also the fixation depends on how good the bone stock is, the bone quality is. Like you said, in case of osteoporotic bones, there are many chances it can collapse or go into varus further despite a good fixation, or the screw might cut out with the collapse, even if the position was good intraoperatively and postoperatively. So in such cases, do you think there is any role of electrous bone grafting or fibula stud grafting in such cases, or combination of both?
Yeah. I have used fibular stud graft in non-unions and in anatomical neck fractures when osteosynthesis was a must and patient was not willing for any prosthesis. In these cases, in patients above 55, 60, I have used fibular stud graft. At times, when I find intraoperatively, if the bone stock is poor, sometimes I use tricortical iliac crest graft. Sometimes I use additional plate on the medial side to prevent varus collapse.
Okay, ma'am. Thank you.
Thank you, ma'am. Ma'am, I had one question. How easy is it for you to incorporate the fibular graft in the in between, and how
so you have to place the fibular graft in the canal of the distal fragment, and in the head fragment, it should support the inferomedial cortex of the head so as to prevent varus.
Thank you, ma'am.
Fibula should go medially, not laterally. It should be parallel to the calcar, and it is in this. And one of the screw must go through that fibular graft. Then and then it gives a very good fixation. Otherwise, there is a translation of the fibula, and if the screw purchase is not there, it doesn't not going to give the result.
Thank you, sir.
I think we can move on to the next presenter if there are no more questions. Next is Dr. Neha. Dr. Neha, who is going to be presenting. So Dr. Neha is an arthroscopic surgeon. She is from Nagpur. She has done her fellowship from the US, and she has Neha. Let's let's start
sure.
if you're ready with the case.
Right. Can you see my screen?
Yeah, it's visible. Go ahead.
Good evening, seniors and colleagues. I'm Dr. Neha Godghate, consultant at Grace Orthocare, Nagpur. For today, I have selected a shoulder arthroscopy case for its uniqueness. In this era of global instability, we as orthopedic surgeons all strive to give our patients the best physical stability. In this presentation, I'll be talking on shoulder instability. The spectrum of shoulder ailments change age-wise. When we think of shoulder instability, the picture which comes to our mind is a young sports person. However, now we also find instability in active elderly population who now wish to pursue more productive and challenging life. But the pathological spectrum, as far as instability is concerned, it differs between young and elderly, hence needs a specific management plan. So how this pathology is different? In contrast to young patients, where a major force is required to dislocate the shoulder, in elderly patients, this can occur even with minor force like jerk while drying the clothes or pulling the curtain off the windows, etc. And the reason is ligaments are now less elastic. As a result of these biological changes, we get to see more of the capsular lesions in elderly than labral tears. And neurovascular injuries like axillary nerve injuries are common, and they may lead to deltoid paresis. Again, missed dislocations are encountered more frequently in middle-aged females. In case of missed posterior dislocation, the shoulder is locked in internal rotation. So this may lead to the misdiagnosis of adhesive capsulitis. Dislocations in elderly are often accompanied by tears of rotator cuff and various biceps lesions. So despite of extensive literature on surgical management of shoulder instability in young individuals, there is paucity of literature regarding outcomes in elderly, and controversy existed in management. So this flow chart by Shin et al. In 2016 is an excellent effort to address this dilemma. The recurrent dislocations in elderly is not as rare as once thought. So various studies have reported the recurrence rate in conservatively managed shoulder dislocations ranging from 10% to 31%. So coming to my case, she is a 75-year-old right-hand dominant lady presented next day with history of jerk to right shoulder while she had fall at home. That time she had a sensation of shoulder suddenly popping out and in. She was treated conservatively for 3 weeks, even after which the symptoms persisted. On examination, the supraspinatus was grade 4, empty can full can tests were positive, apprehension was positive, and Job's test was positive at 90/50, and neurological examination was within normal limits. The plain X-ray was done on day 1 to rule out any fractures like GT fractures or humeral neck fractures, and also if there is any evidence of arthritis or bony spurs. In these T2 fat sac axial images, we can very well visualize the detachment of anterior-inferior labrum, that is Bankat's lesion. In this T2 axial image, there is an evidence of marrow edema in posterior aspect of humeral head. This is a telltale sign that the shoulder has got recently dislocated. Another axial image shows pristine subscapularis and biceps is in place. However, there are fluid signals around biceps. So these are the coronal images, nicely delineate cuff tear, and sagittal MRI films are used to see fatty degeneration in muscles. My patient had gauterier grade 1 degeneration in supraspinatus. So coming back to this algorithm by Shin et al., we were able to manage the present case as shown here. The patient was 3 weeks managed conservatively, however, symptoms persisted. So MRI was done, which delineated medium rotator cuff tear with capsulolabral lesions. So the treatment plan was to repair the capsulolabral lesions as well as rotator cuff repair. So patient in lateral decubitus position, once we examined the glenohumeral joint arthroscopically, there was fraying of biceps tendon and anterior labrum. So it was decided to do biceps tenotomy with the help of RF. So labrum was carefully released from medial aspect of glenoid. Here we can visualize some chondral damage near equator. In uniqueness in this case was we can see MGHL nicely seen here, and the capsule was intact, only the labrum was torn. Here, if we can see, this is the MGHL, which is nicely delineated. This is the labrum, which was off the glenoid, and this is the humeral head. There were no capsular tear as we had seen previously. So, sorry. After that, the shaver is used to debride the frayed chondral edge of the glenoid. Then the rasp is used on the medial edge of the glenoid to improve the healing. So this is the rasp which is used on the medial edge of the glenoid. Then single loaded 2.5 mm anchors are malleted into the place and then deployed for Bankart's repair. Pulling up of the sutures to confirm it is solidly placed. A 45-degree shuttle suture is used to pierce the capsulolabral complex inferior to the anchor. This is an important step for superior capsular shift. The monofilament loop is then advanced to shuttle the suture, and then knots are tied. This is the final repair showing a robust soft tissue bumper. After Bankarts, we enter the haunted house with lots of webs, the subacromial space. Gradually, after clearing the bursa, you can see the cuff beneath. In this second video, with the help of RF, we are clearing the bursa gradually. And if we can see down there, there is a rotator cuff, which is lying just beneath the bursa. So major time of the cuff repair is consumed by subacromial decompression, which is a crucial step for good outcome. Here we can see a nice C-shaped cuff tear. Here in the second video, see, this is the nice C-shaped cuff tear. So a 5.5 mm double loaded suture anchor was inserted, and with antegrade suture passer, simple sutures were passed and then tied with the help of sliding knots. This was a final watertight repair, and this is showing a nicely seated cuff tissue over the greater tuberosity. So post-op X-ray confirms a good position of anchor. At the end of 2.5 months, she was able to lift her arm without much of pain. She was able to do range of motion, almost complete range of motion. And at the end of 5 months, to her recent follow-up, she is able to do again full range of motion. The VAS score has significantly reduced. Here I am checking her cuff strength. The supraspinatus is almost near normal. Infraspinatus is almost grade 5. And lastly, checking her stability. Now I'll be checking her stability. So this is at the 90 abduction, 90 external rotation. She is quite stable without any apprehension. So she is happy patient right now. So as far as shoulder stability is concerned, rotator cuff and ligamentous structures act in synergism. Rotator cuff provides significant dynamic stability to the shoulder via concavity compression mechanism. Hence, the loss of cuff integrity is important in case of to maintain the stability of the shoulder joint. The injury to the anterior support, which was traditionally thought to be insignificant in elderly, is now shown to be statistically significant factor in maintaining the stability. So lastly, this is the largest cohort study done in 2020, published in 2020, where 103 patients, elderly patients with shoulder instability were treated surgically. And they showed none of the patient had any instability event at the end of 2 years of follow-up. So points to ponder are shoulder instability in middle-aged is not equal to young active dislocators, and surgical repair of both the lesions is necessary to prevent recurrence and functional disability. And surgical repair yields higher degree of patient satisfaction. So with this, I would conclude my talk, and these are my references. Thank you very much.
Yeah, thank you, Dr. Neha. That was an excellent case. I think many people would try to go and venture with a patient who is 75-year-old. And as you said, that people don't tend to repair the rotator cuff when there is Bankart tear also, or even the Bankart tear gets neglected. not just beyond 75, but beyond say 40, 45, 50, and 60 years of age. So people hesitate to touch them. So is there any role of CT scan in such cases? Now your patient was an acute patient, what you got, like she presented to you a bit early. However, had she been presenting to you a bit late, would there have been a role of CT scan, or with respect to like Hill sacks and glenoid bone loss, or things like that? So, or recurrence of dislocation.
Yeah, thank you, Anisha, for the question. Yes, definitely. If there is a recurrent dislocation, and if clinically, if I find that the patient has mid-range instability, like if the patient has just 45 degree of abduction and she's apprehensive with that much abduction, 45 of Job's test is positive, then definitely clinically, I think that there might be some glenoid loss. And if that is one reason where I would do CT. The second reason I would do CT if I find on X-ray if there is any arthritis, and if I'm not going for or if there is any massive cuff tear which is irreparable, and I'm not going for arthroscopic repair, or I'm going for this thing replacement, shoulder replacement, then I would do a CT. But beyond that, I don't think it is routinely done.
Actually, I want to add something. As this was an older patient, and you saw the fluid around biceps pre-operatively, and you tenotomized biceps intraoperatively. So many times these patients also have frayed rotator cuff tissue, and whenever we are doing tenotomy, we'll do it intraoperatively. So whatever the length of biceps tendon is remaining from its attachment can be used to strengthen the rotator cuff. Actually, I mean, we have been using the part of biceps which is proximal to the tenotomy part to strengthen the cuff repair, especially in these elderly cases, and it works really good.
Yeah. But in cases of massive tear, they really help a lot.
Yeah,
This
yeah.
was kind of small to medium tear, so I thought to be just repair. Yeah.
Neha, wonderful presentation, and it is daring. Most of the time at the age of 75, people do reduction and think that the patient's shoulder should get some stiffness and probably he'll carry on. But on the contrary, you have done something different to achieving a full range of movement at the 75 years of age. It is really commendable. Suppose if I am there, I will not achieve a full range of movement. I will say some stiffness and then carry on. So this is the routine practice, but you have done a good job. Wonderful.
So she is very active female. She stays alone in her home. And in her recent follow-up, she told me that she even lifted a 5 kg of bedding and she forgot that she had been operated for the shoulder. So it was kind of very nice to hear that.
So it's a wonderful. मेहता मैडम सब लोगों ने बहुत बहुत अच्छा प्रेजेंट किया है. मेरे को गर्व है सब ये वुमेन्स विंग के ऊपर. एंड विल हैव अ सेकंड वेबिनार नेक्स्ट टाइम. विदिशा मैडम, सेकंड वेबिनार.
Zarur.
5
so
unique
these are
cases
all
well within time. Sorry, ma'am.
No, these are all very, very bright and brilliant girls, and we have many more. So I think we should go on with this. And thank you so much for creating Anmol. Thank you so much.
पुढच्या वेळी काय करू मॅडम, सर्व विमेन्स विंगची नावं सांगा, त्यांना आपण सर्वांना लिंक पाठवू, म्हणजे दे विल बी ऑन द स्क्रीन मेजॉरिटी.
Sure. That can be done for sure.
म्हणजे काही प्रेझेंट करतील, काही दे विल बी
they can be seen. That is true. Very true.
Neha will be giving a short vote of thanks.
Vote of thanks, yeah.
Yes.
And then please stay on after the recording is off. And let's take a screenshot before that. Everybody please switch on your...
Dr. Ashok Sham, if you are around. Yes.
चलो अभी screenshot.
No, I'm going to take. Dr. Manoj, you can put the camera down.
Yeah,
Thank you. One more, everyone.
Yeah, she's our tech-savvy girl.
Thank you. Yes, done.
So this concludes today's first webinar, WOICE Anmol Series Webinar 1. So this first episode, I hope Gadegone sir will allow us few more episodes.
तुम्हाला 3 एपिसोड दिले मी सांगितलं मॅडम.
Yes, sir. Yes, sir. So first of all, I would like to thank MOA and our president, very own Dr. Gadegone sir, for his innovative idea to have a women ortho webinar series. Thank you for giving us platform, sir. I extend my thanks to Dr. Karne, sir, Secretary MOA, for being a well-wisher for WOICE. I also thank our coordinator, Dr. Manoj Pahukar, sir, for coordinating everything so well. I thank my panelists, Dr. Anisha, Valvi, and Dr. Chasanal for giving us on time yes, in spite of their very busy schedules. I would like to thank Rujuta ma'am, our moderator and our guide, without whom this group wouldn't have been there. And she is our pillar. So thank you, Rujuta ma'am. I would also like to extend the sincere thanks to our speakers, Dr. Binoti ma'am, Dr. Vidhisha ma'am, from whom we always learn something new, who always inspire us every time they present a case. Our young budding surgeons, I thank Dr. Tanvi and Dr. Ishani for their enthusiastic presentations. I also like to thank OrthoTV, Dr. Ashok Sham and Dr. Neeraj Bijlani sir, for giving us this wonderful platform to present our work on such a large level. And lastly, I would like to thank our viewers who are actively participated and who have seen our webinars. Thank you.
Sure. Thank you all again. Yeah.
Thank you,
all.
everyone.
Thank you.
Thank you.
So ladies, please stay on. Ashok, tell us when you've stopped the live stream.
विदिन टाइम झालाय, विदिन टाइम.
Mac, you can stop this.
The recording has stopped.
Okay, okay, sir. Okay, sir.
So Neha, just few tips. It's gone off
I'll
extremely
just
well.
stop the live stream now.
Oh, please. That stopped? No, not yet.